I am so excited to announce my newest baby, a book for parents all about tongue tie. Tongue Tie for Parents is the book you need if you have any questions about whether there's a tongue tie, how to get treatment, if your baby needs treatment, how to go about it, how to make decisions, how to help you and your baby recover. All of that is in this ebook. Every day I get questions from parents like you, and I know you need answers. Tongue Tie for Parents is built from the same step-by-step protocol I use when families sit across from me in my office. It's the information that you need for clarity, for confidence, and to help you make care decisions based on your own goals, because that's what's most important. You shouldn't need a Google search to get answers. You aren't crazy or overreacting. You are trying to figure out what is best for you and your baby. It's here and ready for you. Tongue Tie for Parents is an easy download. You can have it today for only $27. Go to tonguetieexperts.net/parentbook or follow the link in the show notes, because you and your baby deserve clarity, not confusion. You're listening to the Tongue Tie Experts podcast, a weekly program providing information and support for those families impacted by tongue and lip tie and the professionals caring for them. I'm Lisa Paladino, a midwife and a lactation consultant with over 30 years of experience. If you are a parent looking for answers or a professional who is curious to learn more than what you learned in school on this topic, welcome. This podcast is for you. Hi, everyone, and welcome back to the Tongue Tie Experts podcast. Today, I am with my guest, Olena Dobchansky. I am very thrilled to be speaking to Olena because, as you'll see, this is a little bit of a different subject matter than we usually address on our episodes, and I am just thrilled. So let me just read you her bio. Olena is a seasoned clinician and leader with more than 15 years of experience in maternal, child, and women's health across acute hospital settings, primary care, health technology, and program development. Nationally certified in obstetrical and neonatal quality and safety, she blends deep clinical expertise with operational insight to design systems that deliver evidence-based, high-touch, and scalable care. As the founder of the Postpartum Connection, Olena develops clinically grounded perinatal education and decision-making frameworks that help families, particularly those preparing for cesarean birth and breastfeeding, navigate pregnancy and early parenthood with confidence and clarity. Her work advances maternal-child health through innovative, equitable, and operationally sound approaches that bridge the gap between what patients need and how modern systems deliver care. Welcome to the podcast. I am so excited to have you here. And that was a long pedigree and exciting. And I am intrigued by all of the things that you are expert in. But tell us in your own words what you do right now in the world.
Sure, Lisa, an absolute honor, full circle moment for me to be on the pod. Hello to your audience. I'm a registered nurse, I guess, at the heart of it all. So I will mention that off the top because my passion for nursing extends in many different modalities. And this is what we're going to discuss today. One of them, I wrote a nursing theory about nursing. And so when I think about registered nursing as a discipline, from even when I joined the profession, it has changed dramatically. And, I think one of the things about it is that it's very dynamic, but you need to find your place. Mm-hmm. And so in my own situation, I was trained to be an ICU nurse. I went to a second degree master's program to become an RN. So my background is in psychology. And that's relevant here too, because since I was 16 years old and I realized what psychology was, the theory of people's behaviors, thoughts, and actions, I have been truly obsessed since that time. So really majority of my life. And nursing just took that and gave me a framework in order to care for people. And so one of the things that I would say about myself is I provided clinical care for a very long time before I became a mother myself, before I became an IBCLC myself. And so I really was looking at health, I think, in a slightly less personal way. But then when I have my own experience, there's just no universe that it's not going to color your professional life. So in the middle of COVID, I had two babies. My daughter was born in 2021 and my son was born in 2023. They are 17 months apart, and they both had significant feeding challenges with tongue-tie diagnoses. So I kind of told you on the front, I don't usually mention that because it was trained in me not to talk about my personal life, right? But it absolutely colors my theory. It is the reason why, it is the motivating force behind my work. When I think about the clinical knowledge that I had, I was helping so many people, but really that knowledge came into play in ways that I could never have imagined in my own postpartums.
So I want to stop you there because a couple of thoughts are coming to mind. And, it's been years since I thought about nursing theory, and I remember being fascinated by the nursing theories that we learned in school. And if you think it's changed a lot since you've been to school. I graduated nursing school in 1987. Were you even born yet? No.
No, I was on God's green earth. Thank you very much, audience.
So, yeah, I always joke about that so many of the people I work with weren't even born when I started. But so I remember, I think one of the first lines in a chapter, and I don't know why it stuck with me, nursing is an art and a science.
Yeah, absolutely.
And as a young person learning these things, I don't think I understood I was like, art? I'm not an artist. What the heck? Right? But as I have grown and developed and in my practice, both clinically and in teaching, I think why I've been successful is because I do relate to people as a human in that art before the science, right? So I think I've carried that with me as an underlying principle. And then hearing you talk about your theory as I listened to you on a different podcast, I was just lit up by thinking, wow, that's what I've done. And that's what so many of our successful nurses, advanced practice nurses have done without identifying it.
Oh, absolutely. I am putting, and I'm going to use language very specifically as this vehicle because for the reality is the situation is we live in a postmodern moment. The word is dead. We are in a very video modality. Now, of course, not totally dead. We're on this podcast. Come on.
Right. And I love words. Like I am fascinated with words.
Hence, I'm going to call that out. Actually, you connecting with what I was saying it makes sense to me because it is something you've already been doing. You just necessarily didn't call it a nursing theory, or you didn't think of it as this very clear progression because you were living it. It was a lived experience for you. But when we step back and we kind of say to ourselves, what are we doing here? That is basically what I've been asking myself, right? So I have these two kids. It's COVID. I'm working in a tertiary hospital in the middle of Manhattan. I mean,
wow, that must have been incredibly difficult.
Is changing so quickly. Yeah. I was the clinical program manager of lactation. And so in a role that has not been filled, and I was the first one in it.
Oh, that's so interesting because I was the first breastfeeding initiative coordinator at Staten Island University Hospital, the first and probably the only.
And I was very familiar with your work there because of our sister hospital situation.
Right.
So when I think again about just the nature of change, I kind of started asking myself, okay, so now I have lived tongue tie. I have lived this. It's not something that I am clinically educated about and can care plan and can empathize with you and all of these incredibly important things that I was doing. But there is a whole unlock. There is a whole game change experience when you live the fact that these structures, these systems that we have are forces against you.
Mm-hmm.
And so this makes me really think about what are these forces, right? Because for so long, I was in traditional healthcare, what I call traditional healthcare, right? I'm a nurse, I'm delivering care, I'm a program director, I'm trying to scale help.
Yeah, I call it being
right?
in the mainstream system, the mainstream
Perfect.
medical
I
system.
love that. So the mainstream
Mm-hmm.
system. Right. And the entire time I am running my own private business. The moment I was able to identify knowledge deficit from the patients and the physicians, they were very encouraging. When I first started my career, I worked for 3 physicians on the Upper East Side of Manhattan. They were like, "Yeah, learn whatever you want about breastfeeding. Like, absolutely, we'll pay for it." I was like, "This is amazing," because yes, this is collaboration. I know something now that you don't. We're working together. So this whole interdisciplinary aspect of care was always also very interesting to me. But what happens in the 5 years that I am the program manager is there are just no stakeholders. There is no way for me to do what I want to do. And the work continues, but it really is collaborative. And so when you have a physician ask, is rooming in evidence-based? Yeah, there's only so much moral injury that I could really take. And it is the system that is broken.
Yes.
I cannot be more clear that individuals are just parts of this system. And so I'm really kind of tapping into this and I'm like, where have I heard all this before? What is this, systemic kind of knowledge? Because the reality of lived experiences of nurses is that you're a TaskRabbit. There is no application of a larger nursing theory to the day-to-day activity of a postpartum floor nurse.
Oh my goodness. How true is that?
There is none. It just doesn't happen.
Right.
We were saying goodbye to 45-year veterans, and we could not keep 18 months new grads.
Right.
The math doesn't math here.
Yeah. And I remember early on, or for quite a few years, we were actually writing our own nursing notes with nursing care plans.
Oh my goodness.
That we were following. And then we had to
imagine though the amount of brain power that has changed even from that time. Why?
Yeah.
Writing things down uses a different part of your brain. Thinking cohesively and out of the box to try to get your patient what they need is a whole nother universe than what we do.
Right.
It is just very different. And charting to the chart, like, we don't have to waste time on this, but it really just made me think about what is my part in this healthcare system? I have all this knowledge, right? I am a subject matter expert at this point, right? Do I know everything? Absolutely not. No way in the world. But I'm starting to think to myself, I need new skills. I want to understand how to deliver care in a different way. And so I actually leave the hospital and I go essentially into corporate health in the lactation sphere. And that was just another eye-opening experience, right? Because you don't know what you don't know. You've got to constantly learn. This is the way that I think about it. But I'm really kind of in this world of like the healthcare dissemination. And the more that I'm now in the corporate world, I am more interested in this commercialization, right? Because we are now entering, the hospital is a for-profit system. It's a real sneaky way of doing that, where, the corporate world is very for-profit, and that's right up in your face, right? So I said to myself, okay, like, we have these forces that are so strong. Are they actually one system in itself? Am I dichotomizing the mainstream healthcare delivery system with commercial interest and commercialization as this being a separate thing? And so I said to myself, holy guacamole, no, it's all one thing.
Yeah,
and
because I mean, the hospital systems are pretending to be not for profit, but They have to
No,
make
no, no. I
money.
mean, again, that truly aside, what the hospital is not able to do is care where there is no care. So the first 1,000 days, there has been traditionally very little interdisciplinary care that is mainstream. You go to your pediatrician, okay? Answered a question this week on one of the many modalities that I answer lactation and breastfeeding questions. And the woman says, the pediatrician noted a small tongue tie and my nipples are bleeding. And I said to her, did the physician offer you a care plan? And she said, to change positions. This is malfeasance.
Yeah.
This is not okay.
Yeah.
So this is, again, your audience is like, of course, this is happening all over the place. This is, let's not beat a dead horse. But to the point that there is a vacuum of the first 1,000 days that now all of these companies, some that I work for and consult with, are trying to get in to try to provide care.
Right.
It's not clinical care per se, but is it? What defines clinical care? I am a clinician. I can't stop being a clinician. This is my knowledge base.
Right.
Am I also a care provider? Right? I suppose so. So I'm looking at these two worlds and I'm saying to myself, okay, I have been a lactation consultant for a decade, right? I've been a nurse for longer than that. What is going on? What changed? Because I can tell you that January 2024, I'm at the bedside and every single person is saying, I got all my education from TikTok. I got all my knowledge from Instagram.
Right.
It was like a light switch.
Right.
And it was interesting to me because maybe all of a sudden this algorithm changed. I'd love to have details if this is possible to substantiate this. But my true clinical lived experience was all of a sudden everyone's getting commercialized interest as education. So I say to myself, what am I doing here? What am I doing here? Okay. So I'm going to ask 3 questions that I'd love to meditate on the rest of the pod for. Do our views and practices of child rearing reveal the extent to which commercial interests have shaped them?
Wow.
How much of today's emphasis on individual choice is itself a product of commercialization? And then what does this have to do with tongue ties?
Moms, you know those mornings when you wake up groggy, your mouth is dry, and you feel like you didn't sleep at all? A lot of that comes from mouth breathing, not just a long day with the kids. That's where OI tape can make a huge difference. It's a gentle, medical-grade mouth tape that helps you breathe through your nose while you sleep. It might sound a little unusual, but the results can be seriously life-changing. Deeper rest, more energy, and even less morning puffiness. And for parents especially, good sleep isn't a luxury, it's survival. What I love about OI tape is that it's hypoallergenic, toxin-free, made in the US, and comfortable enough for all-night wear. As a listener to this episode, you can save 20% on all OI products with coupon code TONGUETIE20. So if you're ready to breathe better and actually wake up rested, head over to oitape.com today. Wow. So I just have a quick thought. I mean, individual choice can be interpreted in a lot of ways. And
of course,
what I think about is our choices are based on what we've been taught or what we've experienced, right? So, and what we're exposed to. And if all we're being exposed to
absolutely, yep,
is TikTok and Instagram and this one's saying that and that one's saying that, how are we going to know what's real? And then when someone hits my office or now my virtual office and comes up with this thing that, oh, I heard blah, blah, blah. And I say, no, actually this, and it's the real truth. And it hits them in their hearts. And they're like, why hasn't anybody told me this?
Right.
I'm like, well, because nobody's making money off of you
It's
knowing
because
this.
I'm gonna do one better, Lisa. There is no such thing as health literacy. We're coming out of the cave. I am a philosopher where I'm bringing everybody out of Plato's cave. Okay, there is no such thing as health literacy. Why? Nurses really, this is the domain of the nurse, in my opinion, right? Competencying, understanding knowledge deficit. What do you know? What do you not know? What can you actually do? Right? Because if we think about the hierarchy of medicine, I love doctors. I have nothing against doctors, against the systems that are broken here. But the physician is a diagnostician. There, in my understanding, is not very much education that they are required to do as a part of their job, right? Their job is to have all of this knowledge about what could be possibly wrong with you. Because then when you think about healthcare dissemination, they call in a script, right? It's the pharmacist that says, whoa, 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 you can't put him on this and this and this.
Right.
It's the nurse that says, whoa, 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 he can't do that. It's a social worker system. What are you talking about? There's no abilities here, right? And so it is a system. It's always been a system, right? But what has happened? Commercialization got right on in there. In maternal child health, there is no real difference between the commercial interests and your health. This is scary, but this is the truth. And I think what we need to realize in the breastfeeding and lactation community is that they are changing the language in which we speak about our health. And this is the genesis of the theory. What are we doing here? What is breastfeeding? I suspect a lot of your, and I have listened to many of them, episodes are talking about the how, right? And this is in general. Our education is very focused on how. I have a library in one of my rooms here dedicated to lactation and breastfeeding, right? We got a lot of words on how to position the baby, how to manage production, how to troubleshoot the latch. These are essential skills, ladies and gentlemen, but it's not enough. You need to ask yourself as a clinician, yourself as a parent, yourself as a support person, what is this? What is breastfeeding? What does it represent? How does it exist? And what meaning does it hold? Because if we're not doing that, the care, if you're a clinician or a care provider, mechanical, reductionistic, and disconnected from the lived experience of the family. This is ontology. So if you followed all of that, congratulations, you're a philosopher too. This is ontology. This is the branch of philosophy that is interested in the nature of being, in meaning, okay? And so it's not enough to just say, do it, without contextualizing in a world that does not support it, right? We can't do that. That does not work.
Yeah, and it's so individualized if you are applying the theory of lived experience to that family sitting in front of you. And I say family because this isn't just about the baby. This isn't just
100%.
about the parent who's breastfeeding. This is about the family and the dynamic and the history. And you know, when I take an intake, I ask the history. I ask if this woman has been breastfed. Does anyone in your family breastfeed? What does breastfeeding mean to you? What are your goals around breastfeeding?
There it is. That is the one that almost everyone asks. That's the closest we get to what does this mean to you? But it's not the same thing.
Right.
Asking someone your breastfeeding goals, even to me, I would have said, I want to breastfeed for as long as I can.
Right.
I mean, right? But that in and of itself is not really too specific.
Right.
Right? But what does this mean to you is unsettling. It's an unsettling question because, again, we are trying to support what I would argue is the lactation and breastfeeding. And we will discuss in a moment what I mean by that, right? But from how to what is. And so it's very hard to answer a lot of these questions often. It's very hard to ask yourself. If you are in an established practice, if you roll in every day, what am I doing here, right? You don't want to upset the apple cart. But what I'll say is in applying Martha Rogers's theory to ontology, to what is breastfeeding, I discovered a whole framework and theory to really dive deeper than just what. It's what is and how, right? So when we think about who Martha Rogers is, you mentioned nursing theorists before. Martha Rogers and I are 1 degree separated insofar that Judy Lothian, who was my nursing school professor and the head of Lamaze for many, many years, was her teacher.
Wow.
And so I learned about, and most of my professors at Seton Hall actually did go to NYU in the 60s and 70s, and really an unbelievable academic experience from that perspective. So Martha Rogers is the architect of nursing as a science of unitary human beings. Martha Rogers is born in 1914 and dies in 1994. So she has a really nice long life, and the amount that she did in it was significant. She's a nursing theorist, she's an educator, and truly a visionary. She redefines the discipline of nursing. And so we really see this unfold in her work published in 1970, which is called The Theoretical Basis of Nursing. Mm-hmm. And so she really is kind of seen as this woo-woo, which is, of course, historically what happens to innovators who are of the double X persuasion.
Mm-hmm.
And
why I adore her.
And so when I think about it, what she really is trying to do is get away from this task-oriented biomedical model, which the nurse is subservient to the physician, to a holistic, energy-based, I did say that, energy-based, systems-oriented science. That is her contribution. And so I said, what is the lived experience of a nurse right now? It's a TaskRabbit, right? Yes. If you're in traditional care, if you're running your own business, that is a whole nother kit and caboodle. So I'd like to just share this quote of Martha's, because I think it really does speak to what she was doing. And it will be about nursing, but lactation consultants who are not registered nurses, please see yourself in these words. I welcome that. Nursing's story is a magnificent epic of service to mankind. It is about people, how they are born and live and die, in health and in sickness, in joy and in sorrow. It is the mission. Its mission is the translation of knowledge into human service. Nursing is a compassionate concern for human beings. It is the heart that understands and the hand that soothes. It is the intellect that synthesizes many learnings into meaningful administrations. Theirs is a promise of deep satisfaction in a field long dedicated to serving the health needs of people.
That's beautiful.
When we think about why and what we're doing, we really have a richer experience that we share with the patient. Mm-hmm. It is not anyone who has been a patient knows what it feels like when there is transaction of care. When someone does not give you eye contact, when someone appears distracted, mm-hmm. When you're sitting there with your loved one in a hospital and someone doesn't even turn the light on and says everything looks good, mm-hmm. right? These are things we do not forget. Right. And so as a result, I kind of take science of unitary human beings and I apply it to my subject matter expertise, which is lactation and breastfeeding.
So at this point, I'm feeling a little sad because I'm feeling sad for nurses who don't get to do this. You know, I'm no longer at the bedside. And one of the reasons why I'm not, and sometimes I feel sad about it, was because I wanted to continue to practice how I learned to practice in school, theoretically. And when I tried to be that in the system, I got door slammed in my face. You spend too much time with that patient. You don't have this. Now you have 4 more patients. You have to get this chart done. You know, all the things that you had to do. Sure. But at least I had that basis. Yes. I don't think nurses today, and I just had a family member in the hospital.
It's a tough one. I would have them speak to it, but
there was none. There was none of that. I don't think anyone sat by her bedside ever.
Did they have a preceptor? Was there a nurse educator, or were they?
No, this is the nurses on the floor even.
Oh, the floor
The
herself.
nurses on the
Gotcha.
floor. Like, did she get good care? She got everything done for her that she needed done. She got the medicine when she needed. She got the whatever. All the boxes were checked. Nobody came in and sat next to her and said, "How are you today?" Right? Are we meeting your needs?
One of the most, and I will, and truly, like, I have flashbulb memory. I'm going to give my amygdala and hippocampus to science because I'm sure they're larger. But I had this patient, and I do my thing, which is I say hello, I give eye contact, I address the support system at the bedside.
Right.
I am looking for eye contact. If I don't get eye contact from you, that's a whole nother kit and caboodle. But I also said, do I have consent to touch you? And the husband said, nobody in this entire equation from the moment she got pregnant ever said anything like that.
Right.
And I said, this is how I practice.
Right.
So there are so many, for people who are listening, who are more novice, there are lots of opportunities to differentiate yourself. What you cannot have happen is burnout at the expense that you're providing superior care in a system that is exploiting you.
Right.
So when we think about, back to my theory, that idea of what are we talking about, we need to define terms. And in my theory, I believe, and I believe this with my whole chest, that lactation is something different than breastfeeding. Lactation is the physiological process of producing and removing human milk. Mammals do this. All mammals lactate. Right. Okay. I would argue, is a dog breastfeeding? Is a manatee breastfeeding? I don't know because I can't ask a dog what their lived experience of this is, right? Is there love? Is there oxytocin? I'm sure, right? But when I think about human beings and when I think about tongue ties specifically, what we do is we keep you lactating. And breastfeeding has become a real art for the people who know how to make this work with two humans that are not you and influence this in a way that is benefiting, again, not you, but the dyad. This is an art. It is, in my opinion, pumping is more of a science at this point. Because again, you're not asking the pump, how are you pumping? How is this feeling? I'm not talking about the mom. I'm asking literally the pump. Because the pump is a tool. The pump will keep you lactating.
Right.
Okay. Breastfeeding is a behavioral and relational act. And I define this as transferring milk directly from the breast to the infant. It is dynamic, it is co-regulatory, and it is defined by such. So, breastfeeding is pumping. This is a commercialized interest. The pump companies are telling you this, and the clinicians just parrot this. And we need to take a moment to step back to say, what are we doing here? Because again, you're the expert. So when I think about my second child, my Redeemer baby, the one I had to just nurse and be Madonna and the flower crowns, I swore it was going to happen for me that way after what I experienced with my daughter. And he was a clown. I had polyhydramnios of unknown etiology. Ladies and gentlemen, I'll tell you what it was. It's the title of the podcast, right? I did not have gestational diabetes. They tried to work me up. They told me I was obese. I said, the labs, what do you want from me? My son could not open his mouth. The fluid kept growing, kept building. I lost 15 pounds on the table.
Wow.
He was a repeat C. Okay. And so when it wheeled over to, and I gave birth at my place of employment, which I would recommend if that's possible.
I did that twice.
I had a feeling.
The third time I had a home birth because that's
there
how
you
well
go.
the second time went.
There'll be a third time for me, sister. But yes. So he's glued shut. I said, You've got to be kidding me.
Couldn't open his mouth.
My daughter, I nursed 6 weeks of excruciating psychological pain being an IBCLC, because it does not, postpartum comes for you no matter who you are, no matter what letters you have after your name. It is a transformational experience. You are being ripped open. We are not giving people the full facts here. And again, who is taking that? Commercial interest.
Right. Let's go back to what you said about pumping. I think you're very brave to say that.
Oh, yeah. Well, I'm here.
And in our world, as you know, we're always afraid to make people feel bad or less than.
Sure. We are afraid of that, but we're not thinking with our brains, Lisa.
Right.
What we need to be doing is contextualizing the person in front of us.
Right.
When I'm with my client, I'm sure you feel the same way. There's no one else in the room.
Right.
They are receiving individualized and personalized care. Those two things in my mind are two different things as well, right? When we think about pumping, because what is personalized? I address your name when I come into the room, right? That's a personalized greeting.
Yes.
Individualized care is I am spending time with you here. I've got all my check marks, boom, 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 boom. But it could be individualized, but not personal, right?
Okay.
When we think about pumping, again, how am I as an IBCLC supposed to know everything about every pump that has been manufactured?
I laugh because I always say, I don't know.
We've created a whole nother thing that deserves respect. I cannot be more clear. Breastfeeding and pumping are not the same thing, but that's okay, because pumping is its own world. You have flange fitting. You have parts that need to be removed. You maybe know a little bit about the milk ejection reflex. You may know a little bit that cortisol and oxytocin are not compatible. So if you're staring at the pump while you're pumping, that this is not going to be as advantageous. People also do not know that at 3 months, many people will just have a significant drop in pump that does not come back because you've been using a piece of plastic to keep you lactating. You did not get the potential you had of breastfeeding. And again, not everyone will meet that potential.
And not everyone wants to.
And not everybody wants to.
Right.
100%. But what I will rally against is combination feeding being introduced by the formula companies as a way to push their product.
Right.
Combination feeding, again, sure, offering formula and offering the breast, you kind of need a little information about how to really do that if you're going to maximize or continue breastfeeding. And they got in big trouble. The formula companies have gotten in big trouble during the recall, because all of a sudden combo feeding moms were like, wait a minute, I could have just been breastfeeding this whole time?
Right.
Now, back to that health literacy.
Not in enough trouble, if you ask me.
Well, listen. And again, to my larger point, I do not proselytize anything. So my point is to create terms that we can be clear of what we're talking about.
Right.
When you say breastfeeding is pumping, the baby is not on the breast. We are talking about different things.
Yes.
How does this apply to tongue tie? I'm looking at the bottle feeders. When I answer questions via text, I don't need to see someone anymore. When you get to a point where you are clinically understanding of what is happening in the background and what the symptoms show, you can kind of say to yourself, you need support. We're not waiting 2 weeks for you to try to find an IBCLC to try to make this work.
Right.
No, the bottle feeders. Part of my theory, although you would not think about it from this perspective, because it is obviously a breastfeeding theory, this is for my bottle people. Because how many formula babies have tongue ties that go completely unaddressed? The reason why your child has challenges with starting solids with the bottle is because the silicone nipple doesn't say, ow.
Right.
If you talked to a clinician who has experience, they say, no. we gotta take a peek at here. So
Yeah.
the IBCLC is supposed to be an infant feeding specialist. Now that we've expanded as a result of commercial interests, bottle feeding, pumping, all of this to really be the responsibility of the IBCLC. My argument is, again, understand what these things are so that you can better serve your client and their specific needs.
Right.
That's it.
So, like,
It's
getting
not
back to
about,
the bottle feeders,
yeah,
another like more practical thing that I see is that the baby, we're not just missing it because the nipple doesn't say ouch. We're
there's
missing
more to
it
it.
because people don't know what normal feeding or good feeding should look like even on
Yes,
a bottle.
yes, 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 yes. Because where would
Right?
that health
So,
literacy come from?
right.
Where would that come from?
Right. So as long as the baby's gaining weight, whether it be from breastfeeding or bottle feeding, that's all that matters. It doesn't
That's
matter that the baby's taking half an ounce over 30 minutes.
aspirating on the
Right.
bottle. Oh yeah, I've
Yeah.
heard it all. Sure, sure, sure.
So I'm very lucky to collaborate with a center that has an OT and a
Of course.
SLP who work
Yep.
together.
That's how I
And
roll.
I actually was just there the other day for they're really trying to get me to come on a regular basis, but I made a drop-in visit. And I
Mm-hmm.
actually was able to help a bottle feeding mom that beyond what the SLP could do from my instinctual experience of work and why this baby wasn't feeling supported while eating. So
Mm-hmm.
there's a thing that we bring
Yes.
that did I learn this thing that I told her in school? No.
And what is the commercial solution? Buy a different bottle.
Right,
Buy
right,
20 different bottles. Do we
right,
see, ladies and gentlemen, how interconnected this
right,
entire thing is?
right.
Because we do not have separation from our commercial interests.
Mm-hmm.
I don't need to go into who code. It
Right.
literally is taking, think about this, people. It is taking what healthcare can't give you, which is being told you're a good mom. I'm a good mom for buying this formula. You're a
Right.
good mom for buying this stroller. I love, now we've gone into sleep.
Oh, please.
It's not enough to cannibalize feeding, human feeding. We are now going to our undisturbed, unconscious hours, people. We are bassinetting that are moving. We are strapping them in. We are gonna find a way to feed them in there too. And so when you say
Right.
to yourself, how far away are from like the Matrix? We're not
Right.
that far, my friends. I'm
Right.
not an
Right.
alarmist. But truly, the commercial interests are changing the language we use to talk about our health. My
Mm-hmm.
theory has a lot of other things going on in it, and it does go into really a Rogerian ontology. So it talks about pattern recognition, and I'm developing modules ideally for clinicians to perhaps be interested in kind of learning about how I would apply this to clinical practice, because to me, that's the whole meat and potatoes. As much as
Right.
I love being a theorist, the entire thing has to be applicable.
Right.
Otherwise, you're just on some shelf,
Right.
right? But it is something that we need to define terms to be able to better serve the client, because we live in a world where a parent who is exclusively pumping needs X interventions. A dyad who is struggling with the latch but has a lot of production needs breastfeeding support, right? Someone who is lactating but needs an SNS, they are breastfeeding and lactating. We are actually maximizing the entire experience, where we then don't need to do this third thing, which is pumping.
Mm-hmm.
Right? So there's so many different, then you talk about induced lactation, right? There's so many different ways people are breastfeeding. And you hit this point before. I say, as a result of my definition of breastfeeding being this relational act, that the whole family breastfeeds. The mother lactates. The father, the sister, the cousin, the grandma, the toddlers, they're all breastfeeding, because breastfeeding is a health behavior. Okay, it's a health behavior. We know through research that they're not a supportive partner, the whole thing is going to go.
Mm-hmm.
We know, and again, use this, because the number one thing I hear now is, I can't breastfeed my second kid. I can't.
Right.
I can't. And truly, the formula companies are there being like, here's the bottle.
Right,
Like,
right.
here's the bottle.
Right.
Right.
So here's something interesting that I think it was about 3 a.m. that I was thinking about this morning.
A great time for me too.
Yeah. So I know from research, we did a little research project back when I worked at the hospital. We had a very interested breastfeeding mother who was a pediatric resident.
Right.
And she did a project in her senior year to see the difference between people whose mother breastfed them and their success rates with their own breastfeeding. Mm-hmm. And it turned out that, and it was a small sample size, but it was about 70 people. And it made sense.
Not nothing.
80% higher breastfeeding rates at 6 months if you were breastfed. Now, at first,
this is called pan-dimensionality in my theory.
Okay, so
right there in the flesh.
So I always have thought, well, that's because that's how they learn or whatever. Then I was thinking about it, and this is like really out there, but
try me.
Yeah. I was not breastfed.
Mm-hmm.
I wish I was breastfed. Right.
I
was not breastfed.
Mm-hmm.
I struggled with breastfeeding my kids. My mother tried to support me. By the third one, she was pretty supportive because I had converted her by that point.
Yeah.
But I wonder if it's more than just our society around us supporting us, and if it's something literally biological in the fact of receiving that milk and having had those advantages of the breast milk, making you a better breastfeeder for your own kids. Does that make sense?
It does. Pan-dimensionality. We're speaking to pan-dimensionality, which is an aspect of my theory.
Excellent.
And what it means is breastfeeding does not exist in a single moment in time. It's exactly what you just said. Its meaning and its impact ripple backwards and forwards from the prenatal experience, ancestral history. Think about how long we have been doing this forward into future health, identity, and family dynamics.
Right.
Absolutely. Pan-dimensionality. Not woo-woo at all. Martha's got you.
I love it. So to me, that all of this makes me worry as an older person watching what's going on in the world today. And even though feeding at the breast and giving breast milk to our children, both breastfeeding and lactating, are more popular and common now than they were when I was a kid growing up, there's still this aspect of it that they're trying to take from us, as you're saying,
very much
commercialize.
So.
And what does that mean for the future of the world and the future of our species? If we can, and no, this is not to insult anyone who's had artificial reproduction, but we can reproduce without having relations. We can grow a fetus in a test tube. I think I heard of someone who's almost up to gestating completely
in China,
outside the mom.
I saw some wild stuff.
It just blows my mind. Now, this is going so far from tongue tie, but it's not unrelated.
It's right there, my love. It's right there. It's right there because a tongue tie is a cry for help. The function is not there. It requires someone to pay attention to what is going on. And the mother is paying attention. The difference is the mother is seeing these patterns but doesn't recognize them as patterns. Right. And that's when you teach patterns versus, so for example, I'm not going to be the first LC who says this. I don't care what happens at one feeding. Give me 24 hours.
Right.
Nobody wants to know what happens in one specific feeding unless there was some kind of true,
and nobody is going
thing.
And nobody should be diagnosing just by looking under the tongue and not taking the full picture.
Ever. You are looking for family history. You are looking for current symptoms. You are looking for what are the goals, because this is what I'm saying. My practice is dedicated to ties. Nobody else calls.
Right.
And they know there's a problem. And so what is the thing that I started doing rather recently is I come in there and I say, you have retained me because I also do not participate with insurance. Mm-hmm. You have retained me as a private investigator. I am a PI to you. I am not going to rest until we can find the root cause of the issue. And if I have challenges doing that, I have a robust referral system for clinical validity and for therapy because I'm not a therapist, right? But I never talked like that to the patient.
Right.
But they are scared. They don't know what's wrong
Right,
except
right.
they know something is up.
Right.
And so in most of the cases, they actually do know something about ties. And the pediatrician says, you don't have one. In my
Right.
most recent case on Tuesday, the situation was the doctor said they weren't sure. I said, monumental, monumental. It's not funny even.
No.
Monumental, because now I don't have to say, well, let's look at the facts.
Right, right, right. I have a really popular post that I make on Instagram, and I repeat it every once in a while because people love it. And it's, if you don't know how to tell that there's a tongue tie, please don't look and say there isn't one.
Please don't do that.
Right? Like, don't pretend you know and say, oh, there must not be one because I don't know what to look for. You know, so, and yeah.
And again, I had another kind of funny story earlier this week where I was there teaching a CPR class, but it was starting solids. You know, another love of mine. So people are nervous. They want to take a CPR class. They want to do this around starting solids, and people have a million questions about the starting solids process. That's the context from when I was there. So she had asked my opinion about when to start solids, and I said, everything that I look at, and I look at research pretty frequently, for most kids, if I'm going to give some blanket, 6 months, right? And that's also because you're going to start the weaning process early if you start complementary foods. So she says to me, okay, you know, this was a text. And then when I get to the house, she's like, you know, I know you said that 6 months. And I was like, oh boy. Yeah, no, you said 6 months, but the doctor said 5 because there's new research that says if you start cereal for an entire month and then offer allergenic foods, that the symptoms of allergies are decreased because you did the cereal. And so I looked her in the eye and I said, I love research. It sounds like your doctor is citing a research article. I would love to see it. I would love to incorporate it into my oeuvre or whatever the heck I said. And she looked at me like I had 8 heads. And I looked at her like I had 8 heads. And it was that Spider-Man meme where the two Spideys are like pointing at each other. Because to her, what the doctor said is sacrosanct.
Right.
That is it.
Right.
And then what I'm feeling is, why wouldn't you be questioning what the physician is saying on infant feeding? I'm not talking about his croup diagnosis or her diagnosis. I'm talking about this.
Right.
Right. And so we're both kind of staring at each other.
Wow.
Because again, we're talking about health literacy.
Right.
I have a lot of it.
Right.
Right. And when you are postpartum and all of the panoply of mental health that can come with that, how are you not going to trust your doctor?
Right.
This is what is impossible, unfortunately, to really create a checklist or a protocol about for LCs, right? It's got to be, you need to substantiate what you know, but you can't throw someone else under the bus for their knowledge deficit because that does not end well for you.
Right.
Right. Or the commercialized interests that babies sleep better because they get formula or whatever the commercial
yeah, but they're not supposed to sleep better. That's the other.
And that's the education you provide.
Right.
Of SIDS. SIDS happens when someone can't wake up.
Right.
We've learned a lot more. There's genetic components, yada, yada. But the baby is supposed to wake up. That has changed. Again, 15 years ago, you didn't have to tell most people, that the baby sleeps and wakes up, sleeps and wakes up, sleeps and wakes up.
Right.
You want to optimize some of this, but this gamification that has happened without clinical concepts. Where'd my milk go? Where'd all my milk go?
Right.
You
know what?
Something
you were saying a couple of paragraphs ago,
of course,
was about you being the person who puts it all together, looking for
Yes.
as the investigators, the
Yeah.
root cause. And I believe that that's why I have had a successful lactation practice, because I know that people come to me a little bit skeptical, like, why am I paying out of pocket for this? The grandma or the dad is in the corner, like, how much is she charging? And then
no transparency on any of our health. So
and
yes,
then
it's
halfway through, if we get that far, I get why doesn't everybody have someone like you?
sure.
Right.
Oh,
And
you can
what am
convert
I
it. I
doing?
know.
It's not about helping her breastfeed. It's
No.
about connecting all the
Yes.
dots,
Correct.
giving her the reasons why things are happening, helping her understand her experience of things and dad's experience of things and even grandma's experience of things, all at the same time. We
Absolutely.
laugh together, we cry together. I give her a plan. And I almost want to put this in my advertising. Like, I promise you won't be disappointed. Like, I promise you won't feel like
That's
you
what I tell my
overpaid.
clients too.
Right?
I don't say money back guarantee because
Right.
I need those plans.
Right.
But I absolutely am offering, when I teach most of my classes, I will say I am guaranteeing an educational and informative and empowering session. I am guaranteeing that. I'm wildly entertaining. Right. But again, we need to think to ourselves as clinicians, what's the best way to disseminate this care? Right.
How do
And
we make this practical? How do we make this practical?
Thinking patterns, and it's easy for the clinician not to do this. And I'll tell you why. You're a snapshot in time. Most clinicians are not asking for weeks and weeks of data on what was happening. They really can hopefully get some information on, yes, what happened in the past, but the snapshot of what is currently going on. And so we're not living the patterns. The mother is living the pattern, whether or not it's because the child is restricted and can physically only make it 14 minutes every single time. Right? It doesn't matter what time of day, just the baby fatigues at a set point. Right? Why? Right? Why is that happening? Right? Is it anatomical? Does mom have anatomical differences? We can't also be heavy on one side and not heavy on the other. It is completely necessary to holistically assess the dyad. But it helps when you, instead of going individualistic, to really reframe your care as the patterns of what is happening, because breastfeeding is a phenomenological experience.
So in your next steps going forward, or maybe you're doing this already, is your goal to teach nursing students or nurses or lactation consultants how to have this theory be applied in their own practice?
Lisa, it's an honor to even be asked that question, because my issue is, how do I connect what I believe to be a very powerful framework, not just for questioning commercialization, but for just asking, what does it mean to this person? Right? Because you're in service. If we go back to Martha, nursing, we are both nurses, but I would argue the care, right, is a service. You're providing a service to someone, right? And so as a result of that, it really does need to be wanted. I cannot expend energy on the people who don't want this, who are not interested in this. I would be honored to be able to connect with, I envision this, to be perfectly honest, as a salon, where I want people to talk about this. It's not enough to be a continuing education, to be clicking through modules. There's nothing wrong with that. But we're really talking about some very heavy stuff that is not just football, cradle, cross cradle, how to put a nipple shield on. And it will require your personal experience. Mine changed significantly when I had children, right? About, what does this mean to me? Because if you have listened to me talk about this on other pods, the thing that people remember about breastfeeding is what it felt like. They're going to be the analytical people. that still remember what they got on their SAT, right? That are going to be like, I pumped 3,000 hours.
Right.
But most people, I'd argue, it's the lived experience of what this health behavior was.
Right.
And if it's pumping, a lot of people have positive, a lot of people have negative, a lot of people have all sorts of experiences in between. Again, we need to validate that. We need to validate the person who is bringing the baby to the breast against all odds. Against all odds. We need to celebrate that. We need to celebrate the clinicians who are able to do the art.
Right.
Not just keep someone lactating.
Right.
And I know that that's a little controversial, but it shouldn't be. Because again, when we define our terms, when we have it on our terms, not what the pump company is trying to sell them a pump, right? These are tools. We might need them, but it really does, it opens a whole nother world of mutual benefit, of mutual satisfaction to be able to say, hey, listen, like, you doing this affects me. If we're I don't want to say too individualistic because that's a value judgment. We just are individualistic. In order to save breastfeeding as a health behavior writ large, it needs to be out there. People need to be doing it. People need to be talking about it. Ideally, a media empire is designed to try to compete with the forces that exist in other capacities. We just don't have enough of a voice.
Yeah. I mean, I feel like, and this is probably one of my longest interviews so far, this year at least, which is fine.
Okay.
But I think that speaks to the reflective nature that has to be in this conversation. And I feel like I could talk to you for many more hours, but
an honor.
And we will talk offline. But for those who this is going to be the end of this session for, tell us what do you suggest next steps for anyone listening, or how they can reach you, how to keep in touch with your work so that we can watch what happens with your theory?
Lisa, thank you so much for kindly asking. I am very active on LinkedIn, so you can find me there. I believe the contact information will be in the show notes.
Yes.
I also am in the beginning of kind of really finding my voice on Substack, because my theory is going to be disseminated in ways that I haven't really fleshed out yet. Okay. I do have a presence there, and I love reading what people write there. I love the interdisciplinary nature. Most people are actually researchers. And so it's just been fascinating to be on Substack. So you can definitely catch me there. If you have your own work, I'd love to follow you. And then I am the founder and owner of the Partum Connection. So you can take a look at my website and kind of see what I do, and reach out to me via Gmail, via email. I would love, and welcome any kind of conversation. In fact, let's see if we can get a little salon going out of the people who are interested and listened to this incredible podcast. Lisa Paladino, an absolute honor.
Thank you. Thank you so much for being here, and we'll definitely keep in touch.
Fantastic. Len the RN, out.
Amen. Thank you so much for listening to this week's episode of the Tongue Tie Experts podcast. Check out the show notes for useful links about the topics we discussed and for ways to follow us on social media. Please subscribe to us on your favorite podcast app. And if you enjoyed listening, we'd love it if you'd rate, review, and share with your friends and colleagues. Thanks so much. Bye-bye. Are you a healthcare professional working with breastfeeding infants? Wish you knew more about assessing and treating tongue ties? Earn continuing education credits and transform your practice with the Professional's Guide to Tongue Tie in the Breastfeeding Infant. It's perfect for any practitioner who works with infants and their mothers, especially those working through feeding challenges. Learn to identify who needs treatment, build a qualified care team, and provide holistic care options. Discover the ins and outs of frenotomy, including procedure preparation and best aftercare practices. By the end, you'll be confidently supporting breastfeeding families armed with the latest protocols and be part of an interdisciplinary community of experts just like you. Tongue ties are nothing new, but the right way to assess and treat them is. Ready to make a real difference? Join now and become a tongue tie expert. Sign up today at tonguetieexperts.net/professional and become the evidence-based resource that your community needs. To show my gratitude, I'm offering you a special discount as a podcast listener. Use code PODCAST40 to save 40% off today.